bachelor's in environmental science and a PhD in atmospheric trace metal biogeochemistry in marine environments, both from the University of, I hope I pronounce this right, Plymouth. She is a certified lead environmental auditor, a qualified teacher, and a member of the UK's Institution of Environmental Science and a professional chemist. Christina's responsibilities include the development of air quality and noise policy, and she supports the regulatory process as a technical specialist. She is also Nova Scotia's representative on the Air Management Committee. Today, Christina will be providing an overview of both the roles and responsibility of the Nova Scotia Department of Environment and Climate Change with respect to improving air quality in the province. So I want to welcome Christina up today, and I'm just going to get our PowerPoint up and ready for her. Beginning. I just want to double check both virtual and in person that everyone can see well before we begin. Yes, good. All right. Sorry, there you go. Thank you.
Okay. Hey. All right. Good morning, everyone. It's great to be in a room with people. Before I start, I'd just like to thank the Lung Association for putting this on today. I arrived in Nova Scotia just after the pandemic started. So to be in a room with people again is quite exciting for me, and to see everyone else online as well. So thank you very much for that. I guess most of us attending today will at some point have been involved in research. Okay, so whether you're at school as a child doing research, or those experiments that we do, or throughout your degree or postgraduate, the idea behind research is that we find that unique piece of information that we can add to global knowledge. And when we found that piece of unique research, what we really want to do is to share it with the world. So we talk about it. But when we work within government, we don't tend to talk too much about what we do. And that's not because it's a big secret. It's because generally it's quite routine what we do. And it has to be routine because it has to be consistent. It has to be reliable. That doesn't mean that it's in any way dull at all. As all of us know, working in air quality is never dull. So who are we? So, okay. So our team sits in the Department of Environment and Climate Change, sometimes shortened to ECC, and not to be confused with our federal colleagues at ECCC. This department is split into 4 different divisions. There's climate change, who work on climate adaptation and mitigating climate effects just now. There's a policy division that keeps us right, keeps those procedures going. That's part of the EA branch as well. The EA assessments go into that policy branch, the policy division. There's also our inspectorate, so our inspectorate for compliance and enforcement. And then there's the division that we sit in, and we sit in sustainability and applied sciences. So we're the technical specialists within this division. And in turn, this division is split into 4 different branches too. So there's our colleagues in environmental health. If you were talking about indoor air quality, they're the people you would speak to. We deal with outdoor air quality, the ambient air quality. There's also the water branch. There's the protected areas branch, and then there's ours. And we are the air quality and resource management branch. Our colleagues in resource management, they deal with a whole load of different aspects. They deal with things like contaminated land, waste, pesticides, petroleum, hydrogen. And then there's us, the air quality unit. And we are led by our manager, who's sitting on this table just here with most of our colleagues. And led by manager, we have our intern who's working on a very exciting project, but it's definitely a topic for another time because we could be here all day talking about that one. And then really the rest of us are split into 2 teams. There's our monitoring team and our regulatory team. So who's the monitoring team? So the monitoring team is led by a supervisor. And then there's 3 people working within that team underneath the supervisor. So the data research analyst who deals with all the data, make sure that it's correct, making sure that those numbers that you see that we have public facing are actually accurate. And our 2 air quality technicians who are responsible for going around each of their monitoring sites, making sure the equipment is working correctly, doing all of those checks. And I guess if I said to you, how many kilometers do you think they travel in a year? How many would you think it was close to around about 30,000 kilometers in a year? Okay, so it's quite a lot of traveling that they do, but really necessary. And this team tends to deal with the NAPS program, the National Air Quality Surveillance Program, and their main driver is the Canadian Ambient Air Quality Standards, the CAQS. This information also feeds into programs such as the Air Quality Health Index and the CATMON program. So that data is also available online if you wanted to have a look at it. So this is Nova Scotia split up into the air zones. There are 4 air zones, and we have monitoring stations in each one. This is really why our technicians do a lot of traveling, because they need to go and do those checks on a periodic basis. We operate some of those on behalf of Environment and Climate Change Canada. And, you know, there's 7 sites really that we operate across Nova Scotia. So we've got data from each region. Yeah. And I guess a monitoring site can tend to look something like this. It'll be quite familiar to most of you as to what that monitoring site looks like. You can go online and have a look at the information that's on the left-hand side there as to which pollutants are actually monitored at each location. And then this is something that you might be familiar with, the CAQS monitoring that we do. So every year we report our CAQS results. These colours, if you're not familiar with it, I'm sure most of you are, but they are management levels. So each of the CAQS has a series of management levels. Green being that's great, making sure that you're sort of keeping clean areas clean. And it goes up to red. So that's red would be a case of you need to do something about it. And in between is kind of grades of that. When we're reporting the CAQS management level, it goes on the worst case one. So that's why. So if you're looking at northern, it has mostly greens, but there's a couple of yellows there. So we report it as yellow. And this is 2020 data. I believe the 2021 data is due out shortly. Okay, moving on to the regulation team. So there are 3 of us. We have our air quality engineer, and then there's my role, the air quality protection advisor, and we're both supported by an environmental research analyst. And our main sort of focus really are things like environmental assessments. So we do the technical review for air quality for the environmental assessments. We also provide technical specialist support to our regional offices in terms of approvals. So when an industry applies for an approval as a regulated industry, there are certain terms and conditions that go into that. And some of those relate to air quality. And so we would be advising on that. Yeah, and then the last thing that we kind of really cover as a general theme is our policy. So we're responsible for developing air quality policy, and that's what I'm going to talk a bit more about in just a moment. Our main driver here is the ambient air quality standards. It's not to be confused with the Canadian ambient air quality standards. These only apply in Nova Scotia. We're responsible for developing them, making sure that they're sort of representative of current health knowledge. And we then apply them to regulate industry within the province. That's not what it's supposed to look like. No. Okay. This talks about, the text is all missing, not to worry. Okay, so, so this talks about the environmental assessment that we do. So when an industry wants to start up, okay, there are certain facilities that have to go through an environmental assessment process, and they're detailed in our regulations. And in Nova Scotia, 2 of the main ones just now are wind projects and quarrying. You know, we have a lot of resources within Nova Scotia that need to be dug up, basically, and generally those go through an environmental assessment. So what we would look for really is we would look to see, have they included any baseline information? So what's the environment like just now? Sometimes, you know, for examples of in the wind projects, they tend to be in rural areas. There's sort of very little other sources of pollution out there, whereas the quarries might be a bit closer to roads, because the idea behind a quarry is that you dig up the material, for example, and then it's used within the local environment for road building, for example. So we've been looking for that information on the baseline. Have they thought about the baseline environment, what's happening in the environment just now? The next thing we look at is the impact assessment. So we're looking for dispersion modeling, generally speaking. So with dispersion modeling, we're looking for what assumptions have they used? Have they used relatively reasonable assumptions? Have they used that baseline data within the assessment? Have they really thought about the impacts of their industry as well as what's already happening? And then we provide our comments for the minister to make that decision as to whether these projects would go ahead. Okay, so that's environmental assessment. Again, this is missing as well, but not to worry. This part is about approvals. So generally with approvals, approvals are relate to those designated activities. So our activities designation regulation say which industries need to have an approval. And the approvals cover everything that the industry could influence. So it could be things like technical aspects, noise, air quality is in there too, contaminated land, water impacts, and so on. So we would be having specialists look at the air quality impact. We also advise on those terms and conditions. Are they really getting at what information that we actually need from the industry? Okay. All right, moving on to policy development. And this is my favorite bit, really. The environmental assessment and the approval work are the things that we need to do routinely. So we have, quite a set way that we do that, whereas policy allows us to think a little bit more creatively. So back in October 2021, the government introduced this bill here, Environmental Goals and Climate Change Reduction. And this was a really important development for the work that we do, in that in section 11, there's a goal there. There's 4 parts to it, but it's part D that's of particular interest to air quality work. And this gave us the direction to review and update the province's ambient air quality standards by 2025. This is really exciting for Nova Scotia, really, because it means that we can start to think about all the health research that's going on right now in the world, and really make moves to improve the health of Nova Scotians. If you're familiar with our air quality regulations, you will have seen this table before. So within Nova Scotia, we have the air quality regulations. This is Schedule A. This is our current list of ambient air quality standards. Is anyone quite surprised at that? Does anyone have any thoughts about that list there? It's not very long, really, is it? There's not too many of those ambient air quality standards there. We can use standards from other jurisdictions, so it's not that we'd only look at these pollutants, but it would be better if we had more. Not only that, but these are quite old, and they probably haven't really been updated very much this century, really, thinking about it, from the 1990s. So as you can understand, air quality science moves on really quickly. Think about how much we've learned about the impacts of air quality in the past 30 years. Did we really understand what was happening with PM 2.5 30 years ago? Probably not. So it's a timely event that we start to update these standards. Okay, can't see that there, but it says new ambient air quality standards for Nova Scotia. Okay, so this says, this is really about the process that we are going through at the moment. So we are in the process of updating our standards. We really need to think about which pollutants are released in Nova Scotia. Thinking about our industry, what's important to us here in Nova Scotia? I mean, there's clearly a list of pollutants that we would normally look at anyway, but there are other things that are happening in Nova Scotia that we need to think about, and maybe think about standards for that. We also need to think about which criteria are used across Canada and beyond Canada. We have a look globally at which criteria are used, just to get that idea of what other people are doing. And then we need to think about the current health advice. And we were so lucky that in September, I think it was 2021, the World Health Organization released their updated air quality guidelines. And this was really timely because, you know, we were looking at sort of World Health Organization guidelines from 2005, I think it was. So it was really important that we had that information available to us. And once we put all that together, we then need to think about that Nova Scotia lens. Because as a government, what we need to do is we need to balance the industry, we need to balance sustainability, we need to balance people's health, the economics of it. So there's quite a balancing act that's going on there. Once we came up with a list, we had a collaborative approach, that's what it says on the left-hand side there. We went through stakeholder engagement with a large number of stakeholders, and I believe the Lung Association was part of that. We had a lot of feedback, as you can imagine, sort of taking standards from the sort of 1990s to bring them up to date. There's a lot of a big process to do that, to bring people with us. And really those discussions are ongoing. We have that date 2025 to get them done by. And it's worth taking the time to make sure that they're right. You know, it's a big change for industry. It's a big change for, you know, us as regulators. So it's making sure that that is right. So really watch this space. We'll be seeing some developments on that in the coming months and year and a bit, I guess. One thing we did recognize from doing this work was that we needed to have something to back it all up. Now, up to now, what we tend to do is we give out advice to industry on a one-to-one basis generally about sort of how they should go about their assessment. So if you came to us and said, okay, you've told me you want me to do some monitoring, so we'd go and say to them, well, this is what you need to do. Or if you do some dispersion modeling, this is what you need to do. That takes a lot of time. It takes a lot of time for us. It takes a lot of time for industry. There's always that potential for some small differences to happen. So it's not maybe as clear as it could be. So we put together an air assessment guidance document to accompany the ambient air quality standards. And it sort of gives you an idea of sort of, you know, the questions that might be answered by this document. Simple things like, okay, well, what is a baseline assessment? The document tells you, okay? How should I go about my dispersion modeling? The document tells you, and so on. So it has all of these different sections in there, those 6 sections there. And really, it takes you through the process of submitting, of preparing an air quality assessment for submission. But it's not a start at the beginning and a start and finish at the end kind of document. It's a dip in to take what you need, apply what you need. And then if there are any questions that you have beyond that, then come and talk to us. So it's a baseline sort of how-to guide of preparing an ambient air quality or an air quality assessment for submission to us. And really it's centered on this theme, because what we found was previously industry are very keen on telling us about their impacts on their facility, okay? But for air quality, that's not really good enough. We need to know what else is happening around those receptors, around those people, the air that people are breathing. And the ambient air quality standards are reflective of what people are breathing. So there's a little bit of a disconnect there between the ambient air quality standards and what we were receiving from industry. So now bringing industry along with us again is thinking about, okay, well, you have your emissions, but there's also the other things going on. Some of the other 3 arrows, the transboundary sources, transboundary pollution, the natural sources of pollution, and also those non-industrial sources. So things like traffic, the things that we don't regulate, they all need to be taken into account. Not only that, but there's also those fluctuations that we see naturally in air quality data due to things like the time of day, you know, how close you are to a source, what's happening with the weather that particular day, and things like geography. So it's sort of giving that education piece as well as bringing industry along with us. And again, you can't see there, but it says, for example, so it's referring to those questions again, and where you would go to in that document. So if I have a question about which dispersion models can I use? Okay, so you go into the document, you'd find section 4.2, it says preferred models, and then you'd read through the information there and it would tell you. You might have questions about what mitigation you can apply or how you would apply it. Go to section 5, it tells you in there. And then any more questions, then you would come back to us to ask those questions and have that discussion. So this has been a really big piece of work and we're almost at the end. And when it is published, it will be a really useful document for industry in Nova Scotia. It establishes those clear requirements. So we've got that clarity. We're sort of saying to everybody, this is what we're expecting you to produce for us. And that's across Nova Scotia. So instead of talking to somebody in Sydney and getting one opinion, and then somebody in Yarmouth and getting a different opinion, now everyone can refer to the same document with the same advice. It also means that hopefully, if they follow the guidance, the submissions will be satisfactory to us first time. And that, of course, saves industry time and money, and that's always of an interest to industry there. It frees up a little bit of our time so that we're not having those same conversations over and over again with different pieces, different facilities. Now what we'll have is the time to respond to those variations. Those important details are important to industry and to us. So we can have those conversations without sort of being pressured in terms of timelines and so on. And it just streamlines the approach. It's something that maybe sort of has always been sort of sitting there waiting to happen. And we just had that impetus from having that goal in that particular bill. So it was a really good driver. Ultimately, it means that the ambient air quality standards, whether they're the existing ones or any new ones that come in, are used in the correct way. So the industry is thinking about those other impacts as well and sort of making that assessment on that basis. But the most important thing is it protects the health of Nova Scotia, because that ultimately is what we all want from this. We want industry to proceed, but we also want to be able to make sure that Nova Scotians are protected in terms of the air that they're breathing. If you'd like any more information on anything that I've mentioned there, you can go online. We have published data on the ambient air quality monitoring, and as I mentioned, you can go online, have a look at the map and those other parameters that are monitored at those locations. You can have a look at past environmental assessment projects and the current ones that we're reviewing, and that will also detail the decisions that were made and the different conditions and so on. So that information is all publicly available. Our industrial approvals that are issued to industry are also available online. You can go and have a little look if you are interested in that. And I guess finally, the ambient air quality standards and the air assessment guidance document were both presented for public engagement back in June, July, August last year. And that engagement page is still available. It will give you an idea, you can access the documents there, and it will give you an idea of what we're proposing. There'll be slight changes, particularly I think around the standards of various bits and pieces that we need to look at, but it will give you an idea of what we're thinking about. So until the guidance document is published, which will hopefully be very soon. And I'd just like to say thank you. Yeah, if you have any questions, feel free to reach out anytime. And if I'm not the person that you need to speak to, I can certainly pass you on to whoever you need to connect with. And yeah, it'd be great to hear from you. So thank you.
Hello, everyone. Like Lacey said, my name is Danielle Smith, and I'm the Manager of Citizens Engagement with the Conservation Council of New Brunswick. And I'm here today to talk to you about why switching to electric school buses are good for our children's health. I want to set the stage for you today by talking about the Government of Canada's 2030 Emission Reduction Plan, which outlines a suite of actions the federal government intends to take to meet its target of 40 to 45% below the 2005 levels of greenhouse gas emissions by 2030 and a net zero by 2040. As part of this plan, the Government of Canada has stated its intention to work towards a 35% of total medium and heavy duty vehicle sales being zero emission vehicles by 2030 and 100% by 2040 where feasible. So at the provincial level, the Government of New Brunswick has committed to reach net zero GHG emissions by 2050 and develop in consultation with a newly established advisory body, a net zero blueprint for 2025 that includes transportation, which is the second largest source of greenhouse gas emissions in New Brunswick, accounting for approximately 26% of our total greenhouse gas emissions. The decarbonization of the transportation sector is needed to meet our 2030 and 2050 greenhouse gas reduction targets. This transition will encompass the diverse array of vehicles that make up the medium and heavy duty vehicle sector, from long haul tractor trailers to buses. So the school buses that we're going to be talking about today, they represent the low-hanging fruit in the transition to our zero emission targets, as their routes are predictable and often relatively short. They typically return to a central location between shifts where they can charge, making them the ideal candidate for electrification. The GHG emission reductions achieved by transitioning from diesel internal combustion engines, so otherwise known as ICE, bus to an electric school bus, the ESB, can be significant. This is due to the fact that GHG emissions associated with the operation of electric school bus stem almost exclusively from upstream electricity production. And what I mean by that is that the fuel you're using is from electricity production and not from burning fossil fuels through the combustion engine. The opportunities for emission reductions is greatest in regions where the carbon intensity of electricity production is low, such as British Columbia and Quebec, where renewables and carbon-free sources like hydro and wind are responsible for the mass majority of the electricity generation. Unfortunately, for many of the maritime provinces other than Newfoundland, we don't have the best or the cleanest grids. And Nova Scotia, unfortunately, you guys are doing among the worst with how you produce your electricity generation, because a lot of how you do it right now is through coal. However, I will note that most provinces and territories have committed to net zero carbon by 2050, including Nova Scotia. All right, so I just wanted to set the stage from an environmental perspective because that's where my expertise lies. But as this is a health webinar workshop today, I kind of wanted to focus a lot on the benefits, the health benefits of switching to electric school buses. So in addition to being an important climate solution, electric buses also present notable health benefits to both operators and the population they serve. Electric school buses do not produce any tailpipe emissions, so they do not contribute to the same adverse health effects as their diesel counterparts. Traffic-related air pollution from sources like diesel exhaust has been linked to different issues like asthma, impeding development of children's lungs, in some cases premature death. School bus passengers are particularly susceptible to harmful effects of diesel exhaust, as levels of air pollution are typically higher inside the school bus than they are outside. A Natural Resources Defense Council and Coalition for Clean Energy report found that the diesel exhaust levels on school buses were 23 to 40 times higher than what the U.S. Environmental Protection Agency and the U.S. federal guidelines consider a significant cancer risk. The exhaust from these diesel vehicles can cause respiratory inflammation and reduce lung capacity, and are also linked to many other adverse health effects, including respiratory effects, cardiovascular effects, central nervous system effects, immunological effects, reproductive and developmental effects. Diesel emissions have been estimated to cause over 2 million acute respiratory symptom days and 170,000 asthma symptom days and 3,000 child acute bronchitis episodes every year in Canada. In addition, transportation-related air pollutants such as nitrogen dioxide and fine particulate matter are associated with cognitive development disorders in school-age children, including slower response time, ADHD, anxiety, and depression. Finally, in addition to the environmental and health benefits, electric school buses can have a significant reduction on operating expenses in comparison to their diesel counterparts. Low electricity costs and high efficiency of the electrical engines mean it costs significantly less to power an electric school bus than it does to refuel a diesel school bus. Due to the simplicity of the electrical engine and significantly fewer moving parts, maintenance costs are considerably lower for electric school buses. There are between 45,000 and 50,000 school buses in operation across the country. Most of those buses are fueled with diesel. In addition, a considerable share of that fleet is over 10 years old, so 22% of the bus fleet. Across most provinces in Canada, school buses must be retired when they reach the age of 12. So we do see we have a really great opportunity to switch over those 22% in the next coming years as they're retired. All right, so I'm going to talk to you a little bit about the New Brunswick context. So we have done some research and we have come up with a figure of New Brunswick owning 1,250 buses in our fleet. We estimate that most of them are within the 7 to 10-year life cycle, so locking in those diesel emissions for the remaining years that they're going to be used. Currently, we only have one electric school bus in our fleet, and we have a few propane and gasoline buses, which are better, but still not the best option. So school buses are currently the largest emitter in our New Brunswick fleet, about 22,500 tons of CO2 per year. So the electric school bus movement is growing across the world, and we want New Brunswick to get on board. So what role do we play at the Conservation Council? So we currently have an ongoing digital campaign, which Nikita has so kindly offered to add to the chat for me today. This campaign includes a petition where we're calling on the New Brunswick government to follow the example of our neighboring Prince Edward Island and Quebec by putting in place a mandate and clear targets to achieve 100% electric school bus fleet over the next 10 years. Again, Nikita will include this link for you. So anyone from New Brunswick, please sign the petition. I mean, I think you could probably sign it if you live outside of New Brunswick too. So please share widely within your resources or your networks if you can. Thank you. We have also hosted a webinar on the shift to EV buses and why it's important for the environment, the health, and our children and the economy. So if you want a more in-depth discussion about what I'm talking to you about today, you can please have a look at our webinar, which is also available on our website. And lastly, we have also created 2 fact sheets to accompany videos on how the shift from EV buses will improve our health, as well as one on how PEI is leading the charge and has committed to making the shift to electric buses. Nikita will also provide those links for you. All right, so what comes next? So we're currently working with a production company to create a video highlighting the connection that kids have to our current one and only electric bus in the province. We've heard through lots of stories that the bus driver, as well as the kids that take that bus, carry a lot of pride by being the one and only group of people that get to ride on an electric bus. Our hope is that video will be released at the end of April. In addition, we currently have purple air monitors installed at one of our schools in New Brunswick, and we will be reporting on the results of that, as well as engaging teachers and students about the results at their own school. In partnership with the Ecology Action Center, we will be releasing a New Brunswick advocacy toolkit, and we will be running a large governmental relations campaign, and we will be meeting with local MPs and MLAs in order to advocate for a commitment to the transition of our school bus fleet to electric over the coming years. So I wanted to talk to you a little bit about the collaboration piece on this. So the one really exciting piece about the advocacy project around electric school buses is that we do have a larger Canadian-wide collaboration called the Canadian Electric School Bus Alliance, whose charter is recognizing the significant roles of the transportation sector in urgently addressing the climate crisis. That we look to place the health of children and future generations at its core, creating an inclusive low carbon communities that secure climate justice, while recognizing the necessity for a just and fair transition of school bus manufacturing and operations sectors. Finally, CESBA will be promoting sustainable procurement and manufacturing practices relating to the transport electrification. So because most of you guys are situated in Nova Scotia and some from PEI, I really wanted to give an opportunity to one of our close collaborators at the Ecology Action Center to speak a little bit about the Nova Scotia context. Nikita?
Hi, everybody. Thanks, Danielle, for describing your important work for us. As we do similar work in Nova Scotia in partnership with CESBA and Conservation Council of New Brunswick. And as a lot of you may know, the province has set a goal of reducing emissions by 53% below 2005 levels by 2030 and an ultimate aim of achieving net zero by 2050. One of the ways we are working towards this goal is by exploring opportunities for electric school buses. And for that, the province is already conducting a Atlantic Canada-wide feasibility study for electric school bus adoption, which will help us strengthen our application for various funding streams that are available federally, such as the Zero Emission Transit Fund. As of now, there are 1,400 school buses in the province, out of which 2/3 are owned by the province and 1/3 are contracted out to transportation services. There is an urgent need to release the Atlantic Canada-wide feasibility study in the summer of this year, when CAMET, the Council of Atlantic Ministers of Education and Training, they do a bulk purchase for all Atlantic provinces. At Ecology Action Center, we are working with various government stakeholders and organizations within the province to facilitate and support this process. On the community engagement front, we have number of events and activities planned for this spring and summer to help raise awareness about electric school buses. Recently, we released a toolkit on our website for anyone, a parent, guardian, or any community member who would like to learn more about electric school buses. You can also connect with me. My email's on the screen if you would like to team up with us or collaborate on this initiative. And we believe this is a great time and opportunity to explore electric school buses in Atlantic Canada. Thank you.
My name is Joseph Adosa, and I would like to thank the organizers for this opportunity to present part of our work that we're doing from the Geoscience and Mines branch. That's the Natural Resources and Renewables department. So basically, I work on groundwater monitoring works across the province. We have a couple of sites across the province. We run those sites with our custom-built device that tracks water level across the province. And we also work on, I also work on geohazard, that's the radon gas. And we know radon, it's natural occurring, it's radioactive, it's an invisible gas as well. So yeah, so those are part of the work we do in the province. And our department, basically what we do is that we collect radon data, we map radon across the province because we see that as a way to engage Nova Scotians on, and a part of our awareness campaign as well. And so basically that's what we do in our department. So on radon survey in 1990, a survey was being conducted in the province, and over several hundred homes were being tested for radon. And 8% of those homes that were tested exceeded the health guideline as at that time. And in 2007, due to the revision of the radon guideline for Canada by Health Canada from 800 to 200 becquerel per cubic meter. So the province embarked on a comprehensive survey to test homes across the province, right? So they tested public schools, hospitals, and government-owned and operated facilities. And over 19,000 tests were carried out at that time, and 6% exceeded the 200, the revised 200 becquerel per cubic meter guideline. And it's often assumed, right, that that radon is usually higher during the winter season. So due to that, my department in 2019, we decided to carry out radon seasonal variability tests across the province using a digital detector, right? And we placed that in volunteers' homes for 1 year to collect radon data. And so far, although due to the pandemic situation, we're unable to accumulate so much data between then and now, but so far just 12 houses has been tested, and our result is showing that 8% exceeds the health guideline, during the winter, and while 25% exceeded the health guideline during the summer season. And on radon mapping, right? So in 2013, the Nova Scotia potential risk map for radon was released. And this map was developed using 3 geoscience layers. That's the bedrock geology, the soil geology, and as well the radiometric data. And the map was being validated using over 500 measurements across the province, and to help determine the risks, that's the medium, high, and low risk areas across the province. And the result shows that 40% exceeded the 200 becquerel per cubic meter guideline across the high risk area, and in the medium, 14%, and the low risk areas, about 5% exceeds the health standard. So this tells us that even areas across the province that has that is categorized as the low risk zones should still embark on radon testing. And in 2022, the Nova Scotia community level statistical map was being released. And this map was developed using over 17,000 data set that we collected across between 2007 and 2021, and as well data from our partners as well. And this over 17,000 measurements, but it represents over about 4,700 unique sites across the province, because some sites were being tested over multiple times. And 60% of those data sets were being collected from residential building. And from your screen, the map, the dark green area shows areas where we have more measuring sites compared to the lighter areas across the province. And so these are, this table shows a list of the data sources where we collected our data from. That's from the government surveys, from Health Canada, from the Lungs Association, and the Library Loan Program, and as well those that were being volunteered by home owners. So now, because of the data sources, some are confidential, right? So what we decided to do was that we aggregated radon based on the community level of geography, right? So this layer was being developed by 2 researchers, that's Dr. Natalie Senjak from Nova Scotia Cancer Care, and as well Dr. Mikiko Terishma from Dalhousie School of Planning. So they developed the layer which we used to build this map. And this layer basically it represents clusters of populations and neighborhoods that share some degree of identity among themselves. And in this, their layer that they provided, the province has been divided into 301 environ, that's community environ, you know, to help support health promotions, community advocacy, and as well for research purposes. So on the community level map, so what we did, we went further to develop a criteria on how we can categorize our statistical analysis, how we're going to aggregate them. So the objective basically for us taking this approach was to, you know, include as many environs and while reducing that, while excluding those that has poor coverages. And so from the table, you could see that 28 environs were being excluded because of the had insufficient data sets. That is less than 5. There were fewer sites that were tested for radon across the environ. And as well, we also try to categorize the province based on how the data has been scattered across each and every environ. So environ where the data coverage is more than 30%, so we categorize those environs as adequately dispersed environs, and we have a total of 166 environment that fell within that category. And between 10 and 30% coverage of the total environment area. So those environs were categorized as the moderately clustered, and we have 96 environment that fell within that category as well. And so the highly clustered environment, those are areas where the measurements are less than 10%. So they are just being concentrated close to each other. So this is our map that shows the percentage of measurement across the province that exceeds the health guideline of 200 becquerel per cubic meter. So looking at the map, you could see in the Amherst area, just towards, I think, New Brunswick, the Amherst area, and in the central Nova Scotia, towards the, in the Cape Breton Island and the Sydney area. So those areas, they have measurements that the total measurement, more than 60% of the measurement within those areas exceeds the health guideline. While looking at the community between Truro and, I know it's not very clear, right? Truro and Windsor, right? Along the Bay of Fundy, the western and the eastern shore of the province. So those areas had measurements that less 20% of their measurements exceed guideline within those communities. And like stated earlier, that 28 environs were being excluded because of insufficient data. And as well, province-wide, 22% of the entire data set exceeds the health threshold of 200 becquerel per cubic meter. So this is just a table that shows the summary of our analysis across the province. And you can see about 22% exceed the health guideline from the 4,700, about 4,700 unique sites that were tested across the province. This table shows the 10 communities within Nova Scotia that exceeds the health guideline, and notably at the, I think the Spryfield East and the Stillwater Lake communities. So those two communities had over 70% of their measurements that exceed the health threshold. So in summary, there are no radon-free areas in the province. And as you see from the radon potential map that was released, right, that even the low-risk areas still needs to be tested. So the Geological Survey will continue to conduct testing, collect radon data sets in order to improve our data coverage across the province. And we'll also strengthen our partnership with radon stakeholders to accelerate the radon awareness across the province. And currently, part of our work, currently what we're doing now is that we're trying to use machine learning to train the data set which we are having. That's the over 17,000 data set, and we use that to improve the radon potential map. So that's our current work that's ongoing now. So this sums up my presentation, and I'm ready to take your questions.
To introduce our next speaker of the day, Kim I hope I'm pronouncing your last name correctly, Kim Perrotta. Kim has been doing research, policy analysis, communications, and advocacy on issues related to air quality, climate change, and built environment over 30 years. She is the author of the 2011 Ontario Public Health Association report, Public Health and Land Use Planning, how 10 public health units are working to create healthy and sustainable communities, and the producer and co-author of the 240-page Canadian Association of Physicians for Environment 2019 report, Climate Change Toolkit for Health Professionals. She was the executive director for CAPE from 2015 to 2020, and is currently the executive director for CHASE, the Canadian Health Association for Sustainability and Equity. Today, Kim will summarize the climate mitigation, population health, and health equity benefits associated with investments directed at public transit, active transportation, green buildings and green streets, green spaces, and some innovative work being done by public health agencies in Canada to support the development of public policies that can make our communities climate friendly, healthier, and more equitable. So excited. Thanks for joining us today, Kim.
That's a very long introduction. Thank you very much. I'm sorry if I wrote that and made it so long. I'm really pleased to be here today, and I'm grateful to be speaking to you today from the traditional territories of the Erie, Neutral, Huron, Wendat, Haudenosaunee, and Mississaugas, which us settlers refer to as Hamilton in Ontario. Just to say that CHASE is a nonprofit organization directed and run by public health professionals. And I really want to talk today about the role that health professionals can have on climate change. I'm going to speak specifically about public health, but I just want to say for all of you who are health professionals in the room that it's been my experience over my career, but also a number of communication surveys kind of demonstrate this, that health professionals can be really influential when it comes to winning climate policies. Part of that is because we're trusted and we're deemed to be independent. Part of that is because the health messaging really resonates with people on environmental issues and on climate change issues. People seem to be more willing to take action and to support policies when they think that there's health benefits for them or for their families. The other thing that communication surveys tell us is that while Canadians as a whole are very concerned about climate change and really want to see action on climate change, they can't actually identify any climate change policies. So I feel like we as health professionals have a real role to play in a few different ways. One, we can really educate people about the ways in which climate change is and will impact human health. Two, we can really help people to understand the policies that are needed to actually fight climate change. And three, there's a number of significant climate health and health equity benefits that can be gained immediately for the jurisdictions that take action by when they work to fight climate change. And so those are very strong arguments. And I just want to say this, I've been involved in a few campaigns over the years. I was involved with the the coal plant phase out in Ontario 20 years ago. And we really pushed the air pollution health benefits of that phase out. And that argument really helped to win public support and the support of politicians. So just a really quick reminder, I'm sure I don't need to say it to this room, but that the Intergovernmental Panel on Climate Change has told us that we must reduce greenhouse gases by 45% by 2030, a date that is coming very quickly. And that's actually a global average. The belief in this field is that the countries that have contributed the most to climate change should actually be working more aggressively and kind of reducing by a greater percentage faster than other countries that have contributed less. And Canada has been for decades and continues to be one of the top 10 emitting countries in the world, something that a lot of Canadians don't realize. So just a really quick little summary here of the emissions sources in Canada. And the two top lines there, the blue one and the brown one, that's the oil and gas sector. And the oil and gas sector, it's not our use of oil and gas, it's the extraction and production of oil and natural gas. The brown line is the transportation line. And what you can see with those two lines is they've been increasing on a very aggressive basis for the last 30 years. And oil and gas is actually projected to continue to increase. So these are numbers that we really have to work to come down, and transportation is a very challenging sector to reduce. The red line is the electricity sector, and what you can see there is that we've really made some headway over the last 2 decades, and a lot of that has to do with the phase out of coal plants in Ontario, Alberta, and the Atlantic provinces. And then the one other line I'd like you to note is just that buildings in Canada are actually responsible for 13% of direct emissions, from the burning of natural gas to heater homes, etc. But they're also a large user of the electricity, so they're responsible for a lot of those electricity emissions as well. So what I'm going to talk to you today about is a project that CHASE has been doing with the Canadian Public Health Association and the Ontario Public Health Association for the last year and a half. And it's kind of twofold. One, I've been kind of looking at the health evidence that's associated with a number of climate solutions. And two, we've been kind of collecting some very brief kind of case studies from public health agencies across the country that are doing some innovative work on some of these kind of solutions that we've identified. Now, I just want to say, when I'm saying solutions, I'm using it, broadly. The 5 areas that we're focusing on are public transit, walkable neighborhoods, active transportation, infrastructure, green buildings, greenness and green space, because these are 5 local area, like local, large, broad areas for targeted interventions that have been identified by the Lancet Countdown on Climate Change and Health and by the Intergovernmental Panel on Climate Change. But they're also things that public health often weighs in on, and they're things that we can, we actually public health agencies often work at a local level. So these are kind of the 5 climate solutions that we're kind of focusing on. So I just want to start by kind of just saying very quickly, what do we mean by health inequities? And this is a huge field, but it's been like long understood among health professionals and public health professionals that certain groups within our population are at much greater risk of developing infectious diseases and developing chronic diseases than the general population because of certain social and economic disadvantages. We often refer to the factors that contribute to these, lesser, these health outcomes as the social determinants of health, sometimes the environmental determinants of health. And what the researchers in this field would like us to start saying, because I think we've been kind of saying, those determinants include everything from income and education, it can be immigration status, it can be race, gender identity, mobility challenges. Those are some of the determinants of health. But the researchers in this field want us to start saying and recognizing that the reason these are impacting health is because kind of underlying biases that are kind of systemic in our society that we don't even realize. So kind of recognizing that some of this unequal treatment are things that we need to kind of work to kind of address. And so the idea here is to address health inequities is to address unfair and avoidable circumstances that are causing these negative health outcomes. So looking at public transit, again, we know that public transit can reduce greenhouse gases. It's always identified by organizations around the world as the place that we need to invest if we really want to get transportation emissions down. The other thing we know is that people who use public transit actually get greater levels of physical activity, and that can actually get quite a bit of the physical activity that they need to maintain good health. Thirdly, we know that when we use public transit, we can reduce levels of air pollution. And as many of the people in this room will know, air pollution continues to be a significant concern in Canada. And traffic-related air pollution is itself a huge source of that air pollution. And traffic corridors themselves are a huge problem from a health perspective in terms of premature deaths and asthma exacerbations and chronic disease, cardiovascular disease, etc. So we know that public transit investments, we can actually create substantial health benefits in terms of increasing physical activity and reducing air pollution. But the other thing with public transit is we can reduce vehicle-related deaths because public transit is a safer form of transportation than having a lot of the same people using single-use vehicles, but also that it increases access to jobs and services and recreational opportunities for everybody in our community if we have a really good, efficient, and affordable transit system. We often forget that 20 to 40% of the people in our communities do not drive because of income, age, or ability. And so the better our transit systems are, the more likely we are to kind of have a more equitable society that gives people lots of opportunities to participate. There are also cost savings for people who use transit. And again, if we can actually ensure that kind of low income and other disadvantaged populations are being served well by transit, there can be cost savings for them that can actually be directed towards other essential things such as healthy food and perhaps better housing. The other thing I want to say about transit is that and we can invest in a good transit system, but we also have to prioritize low-income neighborhoods and other kind of populations that will make use of those services more than others. And that's not always the case. My understanding is under COVID, where organizations had to cut back on transit, they kind of did it across the board without thinking about the fact that essential workers were still really using transit quite a bit. So you had crowded buses with essential workers in them, while you had other kind of empty buses in other areas. So active transportation has been examined for 20 years, and public health has been very active in this field. And again, the big, we know that it can reduce greenhouse gases if we can shift a large portion of people over to walking and cycling and get them out of their vehicles. And there are a number of modeling studies that kind of have made estimates of what those health impacts can be, and they can be quite substantial, both again, from an air quality and a physical activity perspective. But I just want to note that in Canada, we have a real chronic disease problem. It's been estimated that chronic diseases cost or are responsible for about $200 billion per year in health-related costs, and they're kind of killing our healthcare system and making it very unaffordable. And so the public health sector has identified active transportation as a way of increasing physical activity and really kind of gaining some of the benefits, the health benefits that can be associated with increased levels of physical activity. So with active transportation, there's kind of the two different bodies of evidence. One is that looks at kind of the active transportation infrastructure. And there's a number of studies that say that when we invest in good infrastructure for active transportation, like separated bike lanes and pedestrian bridges and good lighting and continuous sidewalks, that people are safer and there's fewer accidents and collisions and deaths, but also that people are more likely to use that mode of transportation. And again, from an anecdotal perspective, many of us who work in communities know anecdotally that often it's the low-income neighborhoods that are poorest served by public transit and by active transportation infrastructure. So that's something that we have to really think about in terms of our policies at a local level. And then walkable neighborhoods is kind of the, again, it gets at active transportation, but it's a totally different approach. This is kind of more of a land use planning approach, but looking at how densities and land use diversity and access to destinations and distance to transportation to active to transit stops, how those things, we know there's really strong evidence that these things will create more walkable communities. And we now have very strong evidence that demonstrates that walkable neighborhoods increase levels of physical activity, they reduce risks of obesity and diabetes and cardiovascular disease and premature death. So we know these things happen. And there's also a number of studies that suggest that the health benefits are actually greater for low income and other disadvantaged populations. When they live in walkable neighborhoods, they actually have greater health benefits. And again, so this is something we really need to do, is kind of prioritize those neighborhoods to help make them more walkable. Green buildings and green space have a common health risk, which is extreme heat, which is increasing with climate change. And so I think we've seen over the last number of years, we've seen an increase in extreme events in terms of frequency and the depth of them. And the BC Heat Dome in 2021 is a really good example. And the researchers that actually examined that case more carefully afterwards actually found that deaths in the community, so this is excluding people who live in long-term care and institutions, but deaths in the community actually increased by 440% during the week of the heat dome. And when they looked a little bit more at like how did those death rates kind of play out, they found that low-income populations had higher death rates, people lacking air conditioners did, as did people living in neighborhoods with less greenness. So that's something that we can address with green buildings and green space. So green buildings and building retrofits, we know the International Energy Agency has identified that Canada has huge potential to reduce greenhouse gases very quickly by bringing in standards that would really change the way we build our buildings to make them more energy efficient, to get them off fossil fuels. And that same thing for building retrofits, that there's substantial room for improvement there that can be done fairly easily. There's several studies that suggest that by doing so, we could actually reduce outdoor air pollution and produce some substantial health benefits by doing so. But the other part of it is that indoor environments can actually be a source of a number of negative health outcomes because of extreme heat and cold, mold, dampness. indoor air pollutants and toxics that are released from indoor sources like gas-fired stoves or from consumer products, and even also in terms of like viruses and infectious diseases. So we know that the health impacts can range from respiratory diseases to strokes and premature deaths that are associated with some of these indoor environmental exposures. And so anything that we can do to improve buildings indoors in terms of improved ventilation, improved insulation, shifting people off fossil fuels over to heat pumps, that those kinds of things will actually produce direct health benefits as well as reducing greenhouse gases. And again, just in terms of the health inequities, again, people who are living on low incomes or who, other disadvantaged populations are actually more likely to live in housing that has poor indoor quality or indoor environments. And they're probably more vulnerable to those because their health status is already somewhat weakened by other disadvantages. We also know that a lot of people in Canada, and this is particularly true in the Atlantic provinces, experience energy poverty, where they spend a large portion of their income goes towards paying for energy. If we can reduce the energy used in their homes and reduce their energy costs, that's money that can be redirected to other sources like healthy foods or clothing, or maybe even improvements in their housing. So one of the things that we need to be aware of is that when we're designing programs, our federal and provincial programs and perhaps municipal programs, is that we ensure that those programs will be directed at affordable housing or institutions for different groups, and also that the programs are designed so that people living on low-income populations in their own homes can actually make use of those programs. So greenness and green space is, we know that green space, trees, urban forests, that they can be a significant sink for greenhouse gases. But there's also quite a few studies that have demonstrated that green space, forests, trees, parks can actually reduce levels of air pollution in the local community and also temperatures, and provide some protection from urban heat islands. There's also, though, over the last 10 or 15 years, there's been a lot of work done, research work directly on the health benefits of green space. And it looks like there are huge, the evidence is actually suggesting that there are huge mental health and physical health benefits associated with green space in and of itself. And one long-term study that was done very recently in Canada that looked at 1.3 million Canadians actually found that people who live with higher levels of greenness actually have decreased risks of premature deaths from 6 causes that range from 8 to 12%. So we're actually talking about huge reductions in premature deaths that are associated with just having good greenness, like vegetation and trees in one's environment. So not too many studies have actually looked at the equity, kind of the distribution of green space and that. But again, we know anecdotally, and there are a few studies that suggest that low-income neighborhoods tend to be less green. And so that's something that we should prioritize, again, to ensure that the people in those communities have the benefits of a greener community. So what I want to just kind of turn over now to is just a few examples of public health agencies that are doing some creative work. Ottawa Public Health, which is actually a department of the City of Ottawa, it actually co-located 2 of its staff in the planning department for 3 years when the new official plan was being developed. One of those staff focused directly on the policies, policy hooks, and implementation documents that were needed to embed the 15-minute neighborhood concept into their official plan. And that has now been done. So now they're kind of moving into an implementation stage. The other one actually worked with her planning partners on building resiliency to extreme heat into the official plan, and then developing a high-performance development standard for buildings that has some really interesting requirements in it. One of them is that the buildings have to mitigate health impacts for occupants as well as for residents. So I think that would address issues like air pollution. And it actually has some interesting requirements there to protect fresh air intakes from traffic-related air pollution, for example. In Vancouver, Vancouver Coastal Health It's actually an arm's length agency of the province. It's not associated with a municipality, but they work very closely with municipalities. And they've actually established a healthy environments team to fold social and environmental determinants of health into the built environment. So they're kind of going to key agencies for important planning documents like the long-term transportation plan. And they're going and they're meeting with them and they're saying, these are the public health benefits that we see of your, of public transit. How can we work with you? How can we help influence your policies? And so then they're actually kind of putting in formal comments, and then they're taking guidance from those agencies and those key staff about where they can be most effective from a political perspective. And so the medical health officer is often kind of going and deputing to political bodies when those plans are actually being considered, and making the health arguments and the health equity perspective, bringing that forward to help support the passage of those plans. In Niagara region, the public health department there is part of the regional government. And the region of Niagara has actually agreed that they will have a health equity informed planning process, that anytime there's an operation of the region, a project that's planned, for the region by the regional government, that it has to go through a health equity informed assessment. And right now, public health is actually managing that process. It's brand new in the last few years. But the idea is that every time a project comes up, they have to examine that project and see if there's a potential to either amplify or mitigate the negative health impacts on priority populations, such as low-income populations, for each of the social determinants of health. And transportation is one of those. And in one of the one of the projects that has gone through so far, it was a road reconstruction project that was near 3 schools, 4 adult living facilities, and the health impact assessment actually said, okay, we need to do more here to increase active travel, to ensure the safety of pedestrians and cyclists, and to provide access to services. And then I just got 2 more examples, and I'm really sorry I didn't start my timer. So can I just get a little bit of feedback in terms of how much time I've got left? Okay, I'll keep talking while you do that. I'm really close to the end, but I just didn't want to speak too long.
Yeah, you still have 15 minutes, and that includes some questions. So you're
Oh,
still
that's okay. That's great. Okay. I usually time myself, but I just forgot to hit the timer when I started. Thanks very much. So with Peel Region, again, public health is actually a department of the region. And there in 2012, they did a climate vulnerability report. And then in 2019, they did a health status report. And in both of those reports, extreme heat was identified as a considerable health risk for the region. And so since that time, the public health department decided that it really needed to engage more in issues related to parks and urban forests and tree planting. Before that, they've been doing a lot of work around active transportation and walkable neighborhoods, but they realized that this was an area that they needed to turn their attention to. So over the last few years, they were actually involved in with the region in the development of a tree planting prioritization tool. And so with this tool, some research was done to identify all the various benefits associated with trees, and they tried to kind of divide those up into, from an economic perspective, social, etc. And then they looked at data sources, and this committee that included the conservation authorities, members from the local municipalities, as well as regional staff, they then kind of looked at the weighting of those different benefits. And then they kind of developed this tool. And what Peel Health brought to that process was all the health evidence around the importance of green space in terms of improving mental and physical health, and also the health equity perspective. So they now have this new tool that public health could actually use to kind of identify and prioritize low-income neighborhoods for tree planting to improve their tree canopy. And then my last example here of a public health department, and there's lots of others, but these are the ones I've kind of grabbed for you today. Simcoe Muskoka District Health Unit is an independent public health agency. It works with 26 municipalities, or kind of north of Toronto. It's kind of what we think of sometimes in the south. It's cottage country. So they have a lot of small communities. And so here in some, what they wanted to do in Simcoe Muskoka is they decided they needed to really focus on climate health in the same way that they had done with health equity. And they came up with a 3-pronged program. And one of those was that they really wanted to do research to see how they bring climate change mitigation and adaptation into all of the policy work they were doing. So they updated their built environment policies to kind of really feed climate change in there. But they also wanted to do a scoping review to see what kinds of things they could do from a climate change adaptation perspective. They also then did an education program for all of their staff. And what they said is that everybody, every staff person in public health should be aware of public health, of climate change, and should be thinking about ways that they might mitigate climate change or adapt for climate change through their program area. And then the third one was collective impact. They helped to establish and are facilitating this group called the Climate Change Exchange, and it includes 40 members from all these 26 municipalities, and that includes school boards and hospitals and sometimes just municipal staff, and they all meet on a monthly basis and they share information and they collaborate on projects. So the one last thing that they did that was quite unique is that they contracted an Indigenous consultant to do research on the Indigenous perspective on climate change adaptation. And what they're working on now is kind of that implementation stage. How do they kind of fold that Indigenous perspective into their overall work on climate change? So that's kind of, talking about the project that we're working on. I just want to point out a few important resources for you. One is that the Chief Public Health Officer of Canada just came out with a report a few months ago on climate change for the first time, and it actually addresses the mitigation of climate change as well as adaptation. Kind of the Chief Public Health Officer is taking the position that we as public health professionals have a duty to help prevent climate change as well as to help respond to it. And then these are some resources that Chase produced with the CPHA and the OPHA that you might find valuable. Some fact sheets where we've kind of summarized the health and health equity co-benefits, associated with some of these climate solutions. And then this is the CAPE Climate Change Toolkit for Health Professionals. And this is it's a 240-page toolkit, so that sounds really big, but there's actually, it consists of 8 standalone and complementary modules. So there's one that summarizes the health risks for Canada. There's one that looks at things that can be done at a community level to adapt to climate change from a health perspective. And there's one that looks at healthcare facilities, for example. So that might be a tool that people might find helpful. And there's just a little bit of information about where we get our funding from a disclosure perspective. And that's it.
I want to introduce everyone to our keynote speaker of the day, Rebecca Schneider. Rebecca is a climate change and health specialist with the BC Ministry of Health Climate Resilience Unit, where she supports development of policy and projects that promote and protect health of the population from climate shocks and stressors. Prior to this role, she was a senior policy analyst at Health Canada's Climate Change and Innovation Bureau, where she was co-editor and lead author of the National Climate Change and Health Assessment, Health of Canadians and Climate Change, Advancing Our Knowledge for Action. Rebecca is currently completing her PhD at the University of Alberta's School of Public Health, where her research focuses on the intersection of climate change, adaptation, and health equity. Today, she's going to share findings from the Health Equity chapter of the National Climate Change and Health Assessment, published by Health Canada in 2022. This presentation will establish the complex relationship between climate change and health equity and discuss how climate change can exacerbate existing inequities and create conditions for new inequities to emerge. It will also explore opportunities to increase health equity and strengthen determinants of health through climate change, adaptation, and mitigation activities, and provide resources and tools that can be used to complement efforts. So thanks so much, Rebecca, for joining us today all the way from BC.
Great, thank you. Just make sure you can hear me okay.
That's perfect.
Okay, excellent. So good afternoon, everyone. It's really nice to be able to join you virtually today. My name is Rebecca Schneider, and I want to first acknowledge with deep gratitude and respect that I'm calling in from the land of the Lekwungen peoples, known today as the Esquimalt and Songhees Nations and the home of the Métis Charter community of Greater Victoria. And I'm really grateful to live, work, and play on these lands. So my presentation today will provide an overview of the key findings from the chapter on climate change and health equity from the National Climate Change and Health Assessment. And by the end of the presentation, my hope is that you'll be able to establish the links between climate change and health equity, identify some resources, tools, or approaches that you could use to help center health equity into your climate change work, and also have some knowledge and be able to pull on examples of climate change adaptation measures that promote and advance health equity. I was really grateful to be able to tune into Kim's presentation just before this, and she also provided a number of great examples of this. So just a little bit of background on the national assessment before we get started. So in February 2022, Health Canada released the National Climate Change and Health Assessment, and this was the first national comprehensive assessment I think it was in the last decade that's been published. So 3 other ones have been published, but they were quite a while ago. And this assessment provides the latest evidence and knowledge of current and projected impacts of climate change on human health and health systems. It also discusses who is most at risk to these impacts, outlines the current status of adaptation in the country, including a number of case studies of effective adaptation measures that have been implemented by health units and health facilities. And it also outlines existing research gaps and knowledge needs. And the assessment found that climate change is already impacting the health of people in Canada. A variety of climate hazards impact human health through direct and indirect pathways. So for example, recent health effects related to extreme heat, wildfire events, and the expansion of zoonotic diseases like Lyme disease have been linked to a warming climate in Canada. And indirect impacts through a range of social, environmental, cultural, and economic pathways have also had an effect on health. So for example, the impact of climate change on our food systems. The assessment also found that not only are impacts already occurring, but these health risks will increase as the warming continues. And this aligns with evidence that we've seen in international reports as well. So you may have seen that the latest report from the IPCC was released this week, and it found that with every increment of warming, hazards will intensify. The image on the left-hand part of the slide here is from a 2021 report that assessed the level of additional risk for a variety of health outcomes with average global temperature increases under 3 different emission scenarios. And the example here is the risk of heat-related morbidity and mortality. And the report found that risk will increase as temperatures rise, but the increasing risk is higher under scenarios where there's no climate action or delayed climate action compared to scenarios of increased climate change response. We also have evidence that climate change is increasing risk to health systems and health facilities in Canada. This is just a couple examples on the slide, but we've seen wildfires that have resulted in patient evacuations and displacement of medical staff and costs to the health system. Melting permafrost in the north has created challenges for maintaining health clinics and the services they provide. According to a 2021 study, globally, 67% of cities expect climate change to seriously compromise their public health assets and infrastructure. So this is the first National Climate Change and Health Assessment report that's included a standalone chapter on health equity. And the chapter really explores a number of complex dimensions and points of intersection between health equity and climate change. And it attempts to establish these intersections and really map them out in a way that will allow decision makers and public health professionals to better consider and center health equity into all aspects of their climate change activities. But before we get into the first key message, I just want to remind ourselves again, I know Kim also talked about the definition of inequity, but again, just a reminder, when we talk about health inequities, we're talking about avoidable, unfair, and unjust differences in health. And these differences are typically patterned across the population and often the result of how societies distribute resources, power, and opportunities, and a result of lasting colonization, discrimination, and racism. The statistic on the slide here just helps to illustrate this point. where we see very different life expectancy and infant mortality rates for Inuit versus non-Indigenous Canadians. So this brings us to our first key message from the health equity chapter. So climate change can exacerbate existing health inequities and widen disparities. And it's really these structural systems of oppression that result in health inequities. And in many cases, they're also the underlying drivers of vulnerability to climate change. So this was a framework that was developed for the chapter to help illustrate where and how climate change and health equity are linked. And I'll just walk through it briefly. So you'll see the drivers of inequity at the top in yellow. And this includes social and structural systems and structures. So patriarchy, ableism, cisnormativity, heteronormativity, as well as political and economic systems and structures like capitalism and political and educational institutions. You'll also see structural racism and historic and ongoing colonization. And so these structures all result in the unequal distribution of money, power, and resources. And this influences the status of an individual's determinants of health. So for example, high versus low income, high quality housing versus low quality housing, food security versus food insecurity. And the relative differences in determinants of health can give rise to health inequities. As we keep moving down the framework, we can see that the determinants of health and health inequities influence climate change vulnerability because of their impact on an individual's exposure or sensitivity to a climate hazard and one's adaptive capacity. And this, of course, has implications for community and individual health and well-being. The green boxes on the right indicate the linkages between climate change adaptation and health equity. So adaptation measures themselves can interact and impact determinants of health and influence climate change vulnerability in a positive or a negative way. And I'll get into that in a couple more slides, but first I really wanted to take a closer look at the part of the framework that addresses the complex relationship between drivers of inequity, social determinants of health, and climate change vulnerability. So the differences in exposure, sensitivity, and adaptive capacity, and those three elements make up climate change vulnerability. These result in some people being more severely affected by climate change. So exposure to a climate hazard can differ across individuals and communities, and this could be based on geography, for example. So communities in the north are experiencing warming at an average rate twice that of the rest of the country. And this places them on the front lines of climate change, and so exposure to impacts could be greater. But exposure can also be related to determinants of health. So for example, one's working and living environments. So exposure to extreme heat could be increased for those who do not have access to air conditioning or for outdoor workers. Sensitivity to such impacts also creates differences in how people are affected by climate change. So for example, you'll see on the slide here that people with chronic health conditions are more likely to have a serious health problem during a heat wave compared to healthy people. And an individual's ability to adapt is influenced by a number of different factors. Many are directly related to determinants of health. So for example, evidence suggests that communities that have more resources are better able to adapt to climate change. And this isn't just financial resources, but things like access to information and technology, social cohesion. These can all increase adaptive capacity. Just another example to illustrate this, the BC CDC and the BC Coroner's Service has done some analysis to better understand the factors that increase the risk of heat-related mortality during the BC heat dome in 2021. And that analysis has found that those who lived alone, were socially isolated, lived in a neighborhood characterized by urban heat island effect, and in socially or materially deprived neighborhoods. These were all risk factors. Heat-related deaths were also higher among persons on chronic disease registries. And a study published by the BC CDC actually this week looked at the risk of death for people with different chronic conditions and found that mental illnesses were among the conditions that left people most susceptible to death. And those with schizophrenia were at highest risk. When looking at protective factors, indoor cooling, social connection, so social networks where people are checking in on each other, and living in proximity to green spaces and tree canopy cover, as well as social privilege, were all identified as reducing risks. So we often get asked by decision makers and policymakers about who's most at risk to the health impacts of climate change. And this information can be helpful in determining where resources should be targeted. But as you've probably now are gathering, that answer isn't always straightforward. So all individuals display some vulnerability factors to the health impacts of climate change. But as we've just covered, that vulnerability isn't uniform. There's a lot of different factors and elements that contribute to how one experiences climate change impacts and what influences our ability to adapt and cope to the related health risks. So in the literature, you'll typically see really broad population groups identified as being at higher risk. This typically includes seniors and children, pregnant people, people with chronic medical conditions, individuals with low socioeconomic status, racialized populations, and First Nations, Inuit, and Métis people. I just want to highlight that it's important to keep in mind these groups are not homogeneous, and there's many differences among and within these groups, including strengths and assets that can contribute to climate resilience. And so as research continues in this field and as the understanding of climate change vulnerability evolves, we see increasingly the importance of taking an intersectional lens to understanding climate change vulnerability, including considering how multiple existing inequities can interact and shape and compound experiences and responses to climate change. I also wanted to highlight that in many cases, First Nations, Métis, and Inuit communities are on the front lines of climate change and uniquely sensitive to climate change impacts, due in part to their relationship with and the dependence on the environment, but also due to historic and ongoing effects of colonization and an already greater existing burden of health inequities. It's really important to recognize that despite these challenges, First Nations, Inuit, and Métis peoples have been actively observing and adapting to climate change in a diversity of ways. And Indigenous knowledge systems and practices have been really critical for their resilience and continue to contribute to our understanding of climate-related health risks and the effective responses to adaptation measures. So moving on to our next key message, we know that the health impacts of climate change can be reduced and or prevented if Canada rapidly and substantially scales up efforts to adapt to the growing threats to health. However, adaptation measures are not experienced in the same way across populations and communities. And evidence has found that in some cases, when adaptation measures are planned without considering health equity, the outcomes of that measure may only benefit parts of the population, and they can even inadvertently exacerbate existing inequities. So an example on the slide here is looking at increasing green spaces in an urban center. And this is known to reduce health risks associated with urban heat islands. And as we saw in Kim's presentation, there's a number of associated health co-benefits, but not everyone has access to green spaces. A study in Toronto, for example, found that low-income and racialized communities have less access to tree canopy cover and to public green spaces compared to predominantly white communities. And so developing new green spaces in communities and neighborhoods that currently lack access to them is a potential intervention to address this. But in some cases, new green spaces have led to gentrification and increased property values in the neighborhood. And this can lead to the displacement of low-income residents and small local businesses, which can then further widen disparities. So these are the kinds of things that we need to consider before implementing adaptation actions and ensuring that we design complementary measures to mitigate potential negative impacts. So in an effort to address the concerns with developing new green spaces, for example, adaptation plans may also involve instituting rent control policies and other strategies to maintain housing affordability, really ensuring that the populations that are most in need are being prioritized. And so based on what we've talked about so far, I'm sure it'll come as no surprise that one of the main findings of the chapter is that health equity should be an important focus of climate change and health activities. So things like vulnerability and adaptation assessments and other related knowledge development activities. And across the country, local health units, health authorities, and provincial and territorial governments are taking climate change action, and they're conducting health vulnerability and adaptation assessments in their communities. They're implementing health adaptation measures. And health equity is certainly not a new concept for public health, but there can sometimes be uncertainty in terms of the best ways to center it in our climate change activities. So for example, according to a survey of Ontario health units in 2016, only 42% of respondents applied a health equity lens when identifying, prioritizing, and addressing climate change and health risks in their region. So there are some tools that can help to integrate health equity in our climate change work. And the chapter provides a lot more detail on these opportunities, but I'll just briefly go over some of the examples. So you may be familiar with health equity impact assessments or sex and gender-based analysis tools. These aren't designed specifically for climate change, but they can be applied to climate change activities and policymaking activities. So these are analytical tools, and they can help assess how that project or a policy will impact health equity either in a negative or positive way. Resilience and asset mapping can be quite an important tool. So these are community-based exercises that can identify people, organizations, spaces, and other intangible factors that contribute to community resilience, but aren't typically captured in common sources of data. So it's really taking a strength-based approach and helps to understand what assets exist in a community, and decision makers can use that to inform where vulnerabilities still exist and where protective measures may need to be enhanced or expanded. Similarly, vulnerability mapping provides information on social conditions and climate change vulnerability in a specific region. They're typically based on an index that uses social vulnerability indicators and overlaid on a map of biophysical impacts or projected climate change effects. So Vancouver Coastal Health, for example, they recently developed an index mapping project which measures how susceptible communities are to health effects of heat, wildfire smoke, and air pollution. And when you look at the map, you'll see that climate hazards really affect everyone, but disproportionately impact some neighborhoods. And so decision makers can then use that map to inform the allocation of resources and prioritize implementation of adaptation measures. And I'll speak to community engagement in the next slide here. And so ensuring inclusive, equitable, and community-based participation in the adaptation process is really critical for designing and implementing effective adaptation actions. And a really important component of ensuring that the outcomes of adaptation measures are equitable is to have equitable and inclusive participation in their design and development. And so residents and community-based organizations have really important information that can not only help inform our understanding of climate change vulnerability in a specific region, but also inform what effective adaptation looks like. And in each community, effective adaptation may look different based on existing assets, on vulnerabilities, based on social conditions, and the values and the priorities of the community. So there's not necessarily a one-size-fits-all approach when it comes to adapting to climate change. And that's why it's so important to have the community involved and to really broaden the tent of engaged stakeholders and connect with those who are most at risk to help inform what the response to climate change looks like. And so through engaging residents, we can gain really important knowledge of local and traditional knowledge in the community, past health interventions and campaigns, so what was successful and what challenges were there. And they can also leverage their own networks to help with communication and outreach of these climate change activities. The report also found that adaptation measures, when planned with care, can promote health equity and strengthen determinants of good health, which increases resilience to climate change. And the chapter provides detailed examples and case studies of adaptation measures. And certainly Kim highlighted a number of these as well in her presentation. So I'll just highlight a couple other examples today. So the Healthy Homes in Nunatsiavut is a really good example of adaptation action that simultaneously strengthens determinants of health. And this was a project funded by Indigenous Services Canada. They have a climate change and health adaptation program that funds a lot of Indigenous-led adaptation. The aim of this specific project was to develop climate resilient housing infrastructure that was also culturally relevant, affordable, energy efficient, and reduce the health impacts from overcrowded dwellings and mold, which was a health concern in the community. So it was a really collaborative project. They had high community involvement, and important cultural values informed the design of the prototype multi-unit climate adapted housing development. The design included space to store hunting equipment, a large steel sink for cleaning fish and preparing seal skins, and large open concept living spaces to allow for gathering. And these were all features that were proposed by the residents and then incorporated into the final design. And so this project really was addressing a number of important things for determinants of health. So safe and healthy housing, it supported traditional activities that benefit well-being and build social cohesion, which are all important for climate resilience. The Nurses for Cool and Healthy Homes project is a project in Fresno, California, which is a region that already experiences 92 days each year over 40 degrees. And climate scientists are projecting that to increase by 22 to 30% by 2050. It's a high population or the community has a high level of racialized population, and about 22% live in poverty. And so many also live in crowded, low quality housing without air conditioning, or they can't afford the energy costs associated with cooling their homes. And so this project modified an existing nurse home visit program and equipped nurses with knowledge and tools to help empower their clients to stay cool and healthy during extreme heat events. So they incorporated a checklist for heat risk assessment into the nurse home visits. And so they assess things like window conditions and the presence of working air conditioners and any barriers to paying utilities. And then the nurses could make energy assistance referrals and also health referrals based on their client responses to this checklist. So for example, they were able to provide clients with information on heat illnesses and protective measures, and they also could enroll their clients in utility payment assistance and home energy improvement programs. And I really like this example because it shows that we don't always have to reinvent the wheel here, and that in many cases, public health have existing programs that may just need to be adjusted to address climate change and enhance adaptive capacity. I also want to mention the importance of monitoring and evaluation of our adaptation measures. So despite our best efforts to consider health equity throughout our adaptation process, there could still be unintended consequences or unforeseen negative impacts that result. Climate change adaptation measures are relatively new still, so although we're starting to see efforts ramp up, we don't have a lot of research that's monitored the long-term impacts of adaptation measures. And so we have little understanding of how the outcomes of adaptation measures will impact health equity. So evaluating climate change activities for their impact on health equity is really important. And this will ensure that we're not, inadvertently exacerbating existing inequities, and making sure that we're also collecting information on if the measure is actually working and doing what it was designed to do and protecting who it was designed to protect. So the chapter on health equity in the assessment, it provides some of the emerging tools and frameworks that could help with this. On the slide here, it's a theoretical evaluation framework that can be applied to climate change adaptation measures in any sector. And it assesses the effectiveness of an adaptation measure by evaluating its effect on 7 domains that are relevant to determinants of health. And it also provides indicators and guiding questions to assist users in understanding the positive and negative implications of their adaptation measures. And monitoring and evaluation really should be an ongoing and iterative process. So as time goes on, you might notice that there are parts of the measure that need to be tweaked or reworked to make sure that we're really maximizing the benefits and minimizing any negative impacts. Last couple of thoughts before I end today. The national assessment really highlighted the need for multi-sectoral collaboration in responding to the health risks of climate change. Many policies that affect our health fall outside of the health sector. And you may have noticed that some of the examples I provided today certainly fall out of the jurisdiction of public health. And so it's important that health considerations inform the development of climate change policies and actions across sectors and industries, such as energy development, transportation, agriculture. Public health professionals and others in the health sector really have a role to play in broader climate change planning and can offer important contributions and insights into their colleagues' work in other sectors. And then finally, most of this presentation was focused on adaptation measures, but there's certainly no doubt that increased efforts to reduce greenhouse gas emissions are also required to help protect the health of Canadians. There's many opportunities for the health system to show leadership and reduce their own greenhouse gas emissions and improve environmental sustainability. The assessment provides information on the large and immediate health co-benefits that result from reducing greenhouse gas emissions. So for example, the health co-benefits of taking action on air pollution are estimated to include thousands of avoided premature deaths annually in Canada by the middle of the century. And evidence also suggests that the economic value of the health co-benefits can help to offset the implementation costs of these measures as well. And so I'll leave it there today and happy to take any questions that you might have for me.
Thank you so much for sticking around. We are at a Lung Association conference, so let's take a deep breath. Almost at the end of the day. And I know all of you have a really busy day job, so thanks for taking the time to come to this. I think this first in-person workshop in a long time for a lot of us, but also for the Lung Association itself. I'm actually going to go a little bit in reverse here and start with a thank you slide. I'd like to thank the Lung Association for putting this together. For someone like myself, I'm relatively new to Atlantic Canada. I think I've met several of you here and then at Air Dogs late last year. And so I don't think I had a slide deck ready then to show you about my work. So I really appreciate the opportunity. In a venue like this, we're bringing together NGOs, university colleagues, undergrads on my team, and also governmental organizations together. And I think this is, when we think about multidisciplinary, intersectorial collaborations to advance some of the health solutions that we need, a workshop like this is especially important. And I did also notice that Health Canada provided some funding for this workshop. So those of you from Health Canada on the line, thank you for spending our tax dollars effectively. I also like to thank the speakers from today. You'll find that probably my talk touches on many different aspects of incorporating different parts from what the speakers have spoken about. And I thank them because they covered a lot of the background that I otherwise do not need to cover in my talk. Probably there will be one or two more technical slides, but in general, I'm going to assume some background knowledge that a lot of the speakers already covered. And actually, I think especially our keynote speaker, Rebecca, who's talked a little bit about or actually her entire talk, a lot of it was about the recent report from Health Canada on the health of Canadians in a changing climate, and that there was one chapter in particular, and I encourage you to check it out. She talked about it as well on climate change and health equity. In that chapter, there was one figure that drew my attention, and you might remember it from Rebecca's talk. It's basically this, I would say a flow diagram. We'll also think of it on the left side, or what I would categorize as factors that lead to health effects. That most of the time we think of health effects as negative, or lung cancers or increased rates of diseases. And when I look at the right side, I see possible actions in which we can alleviate some of those health effects. And obviously, I run a research group. I can't possibly focus on each one of these factors. So today, I'll talk a little bit about my groups or my goals for my research group in terms of looking at this particular part, the exposure part. Talking about some of the exposure assessments. Particularly, we ask how high the exposures are. I'll also talk about some of the epidemiologic work that we plan to do and what we've done in the past. And that I think really focuses on the impacts on community and individual health and well-being, and specifically asking how severe the health effects are. But most importantly, my group really tries to center the question of health equity. You'll see later that sort of our motivating statement is really thinking about, with regards to environmental exposures that affect us, how equitable are those exposures? All of us live in different areas, so we probably get exposed to different levels of air pollution. We have different levels of vulnerability. Just, we didn't necessarily think about that when we were about where we're going to live in Halifax. I know when I first moved to Halifax, was looking for a place that was close to Dalhousie, and also just was convenient. I didn't think about the different environmental exposures. I also try to apply that question to our epidemiologic analyses and really try to answer through assessments on how severe the health effects are, how equitable are those health effects. If you and I were exposed to the same levels of air pollution, would one of us have higher risk for a certain disease than myself or other people around us? So to do this, we established the Laboratory for Environmental Assessment and Population Health, abbreviates to LEAF, and we drew a little leaf for our logo. Aline in the back there designed this logo. You see Alex, our PhD student, Aline, who's an honor student right now in her 4th year. Ty, unfortunately, was not able to make it today, but I'll also talk about some of his work this year. So logically, let's start with a little bit on exposure assessment, thinking about how different our air pollution exposures are, and specifically informing that by asking, do we experience different levels of health relevant exposures? This is an air pollution and health workshop, so I'm going to focus on air pollution and first talk about some of the work that I think is the bread and butter of my research program, and that is using satellite remote sensing to determine in different areas what the air pollution levels are. For those of you who are not familiar, we have, I guess hundreds of, maybe even thousands of satellites that orbit the Earth every second of every day. They're constantly taking pictures of different areas on the Earth, and by how much light's being reflected in different spectra, we can get a sense of how much air pollution there is in each tiny vertical column on every spot on Earth. So I'll talk about some of the work that we do with satellite remote sensing first. Specifically, I'll talk about the application of some of the more modern repositories of satellite remote sensing data. Private company Google has gotten into this space over the past 5 years, and they've sort of made it, I think, a lot easier to access some of these satellite remote sensing data. This is a screenshot from the Google Earth Engine data repository about a satellite called Sentinel-5P. It's operated by the European Space Agency, and it measures the satellite remote sensing product gives us an idea of how much nitrogen dioxide, which is a main traffic-related air pollutant, there is, basically everywhere on Earth. And as you can see, I took this screenshot, I guess now a week ago. You can see that the data availability is very recent, that started from 2018, and on that day, it ended on March 17th. So if you check this page now, probably it will be on March 22nd or March 21st. So jumping a little bit ahead, what can we do with these data? Oh, there we go. One of the projects that we tried to do was to ask, does nitrogen dioxide, or NO2, vary by income in different areas of Canada? Now, for this work, unfortunately, I didn't look at Halifax. We just took the 12 largest metropolitan areas according to population in 2016, and looked at how by census tract within those census metropolitan areas, we looked at how different NO2 was in terms of individual income. So we took census data from 2016, which told us what the average incomes of each census tract was. We divided all the census tract within a metropolitan area into quartiles. So H would represent the highest income quartile, while L would represent the lowest income quartile, or the poorest income quartile within a census metropolitan area. And we looked at how different they were in all these different areas. And overall, what we found was that even with the satellite remote sensing data, which probably a lot of you know is not the most accurate measure of air pollution, we find that we see higher levels of NO2 in the poorest census tracts within most of these census metropolitan areas compared to the wealthiest or the highest quartile of income of census tracts within those areas. In every single one of these cities, except for, I think, Niagara Falls, where we saw that the levels were actually lower in the highest earning areas. Another thing to appreciate, I think, from this set of graphs is that, as expected, the larger cities where you would expect higher levels of air pollution, that in fact, from the census data, from these satellite remote sensing data, we see higher levels of NO2 just using the Google Earth Engine data and processing them, actually not by that much using the raw values. Sorry, thanks to, I'm trying to click on Zoom now. Okay, there you go. This work was presented at the most recent AGU meeting, American Geophysical Union meeting. Most of the analysis was led by, at that time, undergraduate student at University of Toronto. His name is Christopher Wu. He's now a master's student at University of Alberta. And I co-supervised this project with Jen Murphy, who's a professor of chemistry at U of T. So now that we have a small flavor of the satellite remote sensing part, I also wanted to talk about some of the work that we've been doing that I believe comes with the community engagement that our group is trying to do. Just like to see a show of hands. Do people recognize the device in this picture? Raise your hands if you do. Okay, many of you do. It's acceptable air, or what we class them as low-cost sensors for PM 2.5. It also measures humidity and temperature. It's low cost because it's around, I think, $240 American, which is probably $1,000 Canadian now. But yet it's low cost compared to some of the gold standard monitoring that's traditionally used in air pollution monitoring that could cost, hundreds, $200,000, and a lot of expertise to maintain and operate. So this is, I think this is Ty's hands here in installing it. He and Aline went to a place called the Deanery, where we noticed that there weren't a lot of sensors in that area, and they sort of offered to host this sensor, and this is them installing this low-cost sensor in that community area where I think there wasn't a low-cost sensor monitoring within 50 kilometers of that area. So really what we were trying to think about is not only was the Deanery interested in measuring how the air pollution is in their area. I mean, it's probably pretty clean, but they were interested in, they have a mission to educate the public about environmental exposures. So we view that as kind of not only community engagement and education, but also to fill in some of the spatial temporal gaps that we have in Nova Scotia in terms of air pollution monitoring. So this is a map of all the different PM 2.5 monitoring sites in Nova Scotia, and also try to include PEI in there. I guess on the surface, you can say that there's actually quite a few. It looks pretty clean. The Deanery site, I don't know what happened on that day, but actually had the highest rating at the time when I took this screenshot. But there are a lot of gaps. Some of them probably some of us in this room live close to, where we do not have air pollution monitoring. Part of our mission is, we have some data from satellite remote sensing, but those measurements aren't, the satellite isn't taking images. It's not trying to take images every hour. And so there's no time gaps. And so with something like a low-cost sensor, we can fill in some of those gaps and even provide data that could supplement that satellite remote sensing assessment of air pollution. And so just to reiterate some of the points with exposure assessment, we conducted some community engaged monitoring. I'm just highlighting this one site. We also operate a site out in Bridgewater. These types of monitoring help us fill the monitoring gaps that we have in Nova Scotia, and also provides data that we can compare with the satellite remote sensing data that's going to be available everywhere, but it would be nice to have some ground level measurements to compare to. Okay, I think I've covered a little bit of the exposure assessment side in terms of some of the work that we try to do to answer how high the exposures are. Next, I'll talk a little bit about the epidemiology side of my lab to talk about how severe the health effects are. And just like to remind everyone, for both of these questions, what the motivating factor really is to think about how equitable both the exposures are, but also how severe the health effects are. And so for the epidemiologic side of our work, we want to ask a health equity informed question. And to make that more specific, we're then asking, are environmental effects more severe for some of us? For this, I'm going to talk about some of my previous work on environmental exposures during pregnancy and a subsequent birth weight. If you can imagine, I'm trying to assess, maybe for some of us, air pollution affects us more, and that affects a growing fetus more than for some other of us, where perhaps if we get exposed to the same amount of air pollution, it might actually affect fetal growth more severely than others. So to do this, the specific question was on the exposure to PM 2.5 and the resulting birth weight of a baby. We're asking, does PM 2.5 affect fetal growth disproportionately? And what we did here was we took the maternal residential average modeled PM 2.5 mass concentration during pregnancy. So if you ever look at birth records, it reports where the mother lives, and under the correct IRB and different research ethics applications, you're then able to access where different mothers live, and based on that residential address, we know when the baby was born. We also have estimate of the gestational age, usually in weeks of gestation. We kind of calculate how much, based on the residential address of the mother, their exposure to PM 2.5 during that time. And we used modeled predictions of PM 2.5 that were available at the 1 square kilometer spatial resolution to determine the average exposure that a mother has during her time of pregnancy to PM 2.5. That side is the, what you would call a predictive variable or the exposure. But for the outcome, what you really want to understand in this case is birth weight in grams. The reason why we look at this is that we all have a birth weight. We're all weighed when we're born, so it's a ubiquitous measure. It's a health outcome that has low missingness. And why we really want to look at this is that the literature has shown that lower birth weights are linked to higher disease risk, not only in infancy, but also during childhood and into adulthood. I did this work when I was a graduate student in Boston, so we used Massachusetts birth records. There were around 1 million birth records from 2001 to 2013. This is probably the most technical slide that I'm going to show. I'll walk through it pretty slowly. This is a graph of the estimated effect of PM 2.5 on birth weight in grams from 2001 to 2013. Now, all of these effects, if you're already looking there on the graph, is scaled for interquartile range in PM 2.5, or around 2.3 micrograms per cubic meter in terms of an increment of the effect. And what you can see here is I drew a line for a no effect. So if PM 2.5 were not associated, or there was no estimated effect of PM 2.5 on birth weight, we would see that all the estimates would really hover around the null line. But instead, we see that increased amounts, or this increment, 2.3 micrograms per cubic meter, is actually associated with a detrimental or negative effect on birth weight. And on average, I illustrated this with this red line. If we took all 1 million births, I'm just asking on average, per 2.3 micrograms increase in PM 2.5, what would we expect on average across these million births would be the resulting effect on the birth weight of a baby. And what we saw was that there was around 16.3 grams on average per that 2.3 microgram per cubic meter difference. Now, that might not seem like a lot, but remember that this is averaged out for all million births, and you would expect that it's probably larger for some of us than others. This is the health equity side, where some of us are more affected than others. And to try to answer that question, what we then did was also predict what the effect of this 2.3 micrograms per cubic meter was among the lightest babies versus the heavier babies. Now, here's where we went into a little bit of technical details. It's where when we are doing regression analyses to produce results like these, we're controlling for many different covariates and what we consider to be confounding variables in statistical analysis or epidemiologic analysis. So these estimates are, in fact, if they control for differences in income, differences in your birth order, because mothers tend to have heavier first babies and every second baby tend to be a little bit heavier than the first one. And so it controls a whole host of potential confounding factors. And even after controlling for many of these confounding factors, we see that among the lightest newborns, there was a more severe effect of PM 2.5 to that birth weight compared to the heavier newborns. And what this demonstrates to me is that even after controlling for the many of the confounding variables that we theorize to exist, there is a there's an inequality in terms of how in the range of different babies that there's larger effects in some compared to others. So I guess the next logical question is then, now what are some of the aspects of the groups that are more severely affected? This is one of the questions that I'm still developing and want to, Alex is actively working on a data request application through the Atlantic Path, which is a cohort of people in Atlantic Canada that we have really good health information on. We're also planning to use health records from the Canadian Longitudinal Study of Aging, which focuses on, I think Rebecca mentioned this, in terms of a health equity piece, that older adults are also one of the vulnerable groups that we think about when we look at environmental exposures. So we're planning to also get data from them to answer some of the questions with regards to which groups are more affected by PM 2.5 and other environmental exposures. And then finally, some of you may have heard of this CANOE, which is a environmental consortium across Canada, and they use a census-based health cohort called the CanChex, which I think takes around 20% of the entire census population to answer questions like, does air pollution affect our heart disease risk? Because fortunately in Canada, we have a public health insurance system. So all of that health information is under one umbrella, and that we can really think about Canada as a whole when we look at environmental health effects. To support this type of work, I'm really fortunate that I was recently awarded this new health investigator grant from Research Nova Scotia. Was actually just talking to Robert earlier today to try to leverage some of these data and work with the Lung Association to really try to tease out some of the questions to support interested researchers like those in my group to conduct some of these research on health equity to answer questions about, are some groups more affected by air pollution and other environmental exposures than others? The last bit I want to reserve to a topic that's pretty dear to my personal experience and my heart. As many of you know, Atlantic provinces are gaining in population, and in recent years, it's actually been more and more new immigrants have come to Atlantic Canada. This is an article from CBC in late 2022. We have Canadian censuses every 5 years. So the most recent census happened in 2021. And the data what showed is that Atlantic Canada, while before in 2006 only got 1.2% of all newcomers from abroad to Canada, it's now at 2021, so it's almost triple. This is another graph of the proportion of immigrants and non-permanent residents that are currently living in Canada as a whole, but also by province. So while Nova Scotia and PEI may be one of the lower proportion compared to provinces like Ontario or British Columbia or even Alberta, these percentages are started to increase. Combined in Nova Scotia, 7.4% of us are immigrants, and you can see that most of us still came before 2016 to Canada, but there's now 2.2% of all of Nova Scotia residents are immigrants that came between 2016 and 2021. And we have 2.3% who aren't classified as immigrants and they're non-permanent residents. So you might think, why does this matter? I think a very underappreciated part in public health, which is ultimately the field that I was trained and come from, is the intersection of immigrant and environmental health. As we have, more and more immigrants in our population, we have a healthcare system that needs to take care of everyone. It means that not only are our healthcare needs, I know this is a hot topic, not only are healthcare needs going to be a little bit different, you can imagine that probably immigrants have different healthcare demands than the population that has existed here for a long time. And often we don't really think about, at least in my literature search, many scholars in immigrant health don't necessarily think too much about, when immigrants come to a new country, what are their environmental health exposures? What are they? Most immigrants come to urban areas, and those areas tend to be higher in terms of PM 2.5 exposures. They tend to live in areas with urban heat islands, so they may actually be at higher risk for some of the diseases that Rebecca has talked about in her review for the Canadian government, and that I think it's a field that it matters to North America, especially Canada, where with high proportion of immigrants in our population, many immigrants are now aging into older adulthood, into elderly. So as people age, they tend to have higher health demands. So maybe if we think a little bit more about the environmental contribution to immigrant health disparities, we can think about ways to alleviate some of the healthcare demands through healthy designs that many of the previous speakers have already talked about: greening neighborhoods, thinking about urban design, green roofs, thinking about switching to electric buses to lower the amount of air pollution that some of the most vulnerable people get. I think that's also a topic that's to be explored, and I think it's going to gain a lot more traction in the general field of environmental justice and health equity. I've already tried to think about this and explore these types of questions in my previous work with United States data. Here I used satellite remote sensing to look at whether or not PM 2.5 exposure and its predicted attributable premature mortality differ for immigrants and those born in the United States. I think eventually I'll try to find a student who would be interested in doing this type of work with the Canadian census data and the new satellite remote sensing data that we're going to use in the next few years. And so I've reserved this last bit of immigration because it is personal story to me on the left. Don't know how clear this is, but this is me on a bike in an urban jungle of Hong Kong, an island of Hong Kong. This is before I immigrated, probably 4 or 5 at the time. And this is me a few years later. And actually, probably one of us recognizes that I've realized as a Dow faculty member, but also didn't grow up. We were actually neighbors. You might recognize this building in the background. This is close to Finch and McCowan in Toronto, for those who have lived in Toronto. And so I guess personally, for me, I didn't think too much about it at the time, but as I reflect on my own life, had I stayed in a concrete jungle such as Hong Kong, I probably wouldn't have, have as much exposures to outdoors or the opportunities to explore the outdoors. And I think that really informed or made me think personally about environmental health and environmental health disparities, environmental justice, and that I didn't get to choose that. I started my life in Hong Kong and then moved to Canada. And so really I guess what I come back to is that I believe that it's unjust that some of us are health disadvantaged from our environment. Topic really here today is air pollution. Don't think that it's right that some of us are health disadvantaged from air pollution exposures, which we're born into or have little choice over. This is my second thank you slide. I'd like to thank the people in my group as well as the Lung Association for organizing this workshop, especially you, Lacey. I think put a lot of work into this. From what I understand, simultaneous translation to French, that must have been very difficult to put together. But I also like to thank the organizations that have supported my work so far, including Research Nova Scotia and the Vice President of Research and Innovation at Dalhousie University. So with that, I'd like to close and thank you for your attention.